in terms of HIV and prevention. There are several different modules within the actual slide deck. And you can see the topics here: identifying patients at risk, reducing risk in populations at risk, and diverse populations. But I know you're an advanced audience and you're an academic group, and I think it's a real treat to go right, and I'm going to jump right to the hyperlink of HIV prevention. What's on the horizon? So this really tells you what's in the pipeline, what's being developed. I think you're all familiar with Truvada and Descovy, and I think this takes it one step further. All of this is essentially off-label, but it's an interesting discussion. So what's on the horizon? So let's start off with a case. So could be somebody living right in New York. So who is this patient, Mrs. BD? 45-year-old woman, has one male sex partner, and they have a conventional contemporary relationship, except that once every weekend, every other month, they join 3 other couples at a sex club and exchange partners. So they've tested HIV all the time, and they checked for STIs every 3 to 6 months, and they've remained negative. The men have previously agreed to use condoms with any vaginal or anal sex, but recently one couple brought cocaine to share, and condom use was less regular. So Ms. BD and her partner have read about PrEP, but they're reluctant to take daily pills. Right? Real interesting. They're negative, but I think you would agree that there's a lot of risk concerns here. So what would we recommend for both Ms. BD and her male partner? And would the advice be the same for both in terms of how we might advise both of them with regards to PrEP? Should she strictly enforce condom use with male partners, especially during receptive anal intercourse? And I think it's a resounding yes. We should try for that. And then what about daily TDF-FTC, Truvada? What about daily TAF-FTC? And what about just TDF-FTC, using it just before and during the sex club weekends, kind of as an on-demand, or something else, or a combination of the above? And what would you need to make your decisions? Lots of thought-provoking questions here. And again, I'm sorry I'm not there, that we can kind of bounce this around amongst ourselves, but some interesting thinking. Not everything is kind of cookie cutter and by the book in terms of what we do in clinical practice. So here's some data from the hypergay study. So not hypergay, these individuals, but it's called hypergay or hypergay. It's a study done in Paris, and it really looked at a different use of Truvada for PrEP. And this was prior to Descovy being available, but and the question was raised: do people actually need to take it every single day? What if they have sex less frequently and they just want to cover the sexual encounter? So there was a formula: 2 tablets, 2 to 24 hours before sex, 1 tablet 24 hours later, and 1 tablet 48 hours after the first intake. And this really informed the Paris experience, certainly, and the French experience, and it went on to prompt a very large study to look further. This is the ANRS Prevenir study. So looking at daily versus on-demand PrEP with this formula, much larger. And this study started beginning of May 2017 and it ended just recently. Or it's actually going to end very, very soon, the end of May. So again, on-demand versus daily PrEP with this formula. You can see the baseline characteristics. So some interim assessment of this showed that HIV infection was very uncommon. In fact, daily PrEP use, it was 0, and on-demand, it was 0.2 per 100 patient years. So the global incidence, with a reference standpoint, is 0.09 per 100 patient years. So PrEP was stopped 7 to 10 weeks before infection occurred in both of these cases, that the individuals that caught HIV in this study. Mean follow-up, about 9 months. So the overall estimate of HIV infections averted was 143. There was no difference in adverse events in both treatment arms. And again, the reduction rate was very comparable with on-demand versus daily treatment. And indeed, in Europe, on-demand indication for HIV prevention is approved by the and you can see that down at the very lower left-hand corner of the slide. The on-demand PrEP strategy is not FDA or EMA approved, but is embraced certainly in France as an alternative. So let's look at tenofovir diphosphate and FTC triphosphate levels in the female genital tract and rectum. So this just shows graphically after a single dose, and you look at time point after a single dose, and you look at the relative tenofovir concentration in rectal tissue, which is the dark, let's say, aqua, dark blue, compared to vaginal tissue in red and cervical tissue in light blue. You see that the female genital tract lags behind in terms of tissue levels with at least tenofovir diphosphate and FTC levels in the genital tract. And this has led to, at least with Truvada dosing, suggesting, certainly from the Prevenir study and the Ipergay study, that there is some adherence and forgiveness that can occur with Truvada. And we see that maximal dosing we give for both individuals, men and women, and that there's perhaps a little bit more forgiveness with men because we see that the genital tract actually retains tissue levels a little bit higher than the female tract. And so we think that likely it's going to take 7 days daily dosing for women, but perhaps on demand, at least with 4 doses, may be protective for men. And we know from the IPREC studies, for example, that led to the approval of TDF-FTC, that really equivalent exposure of 4 doses or more per week was highly effective at reducing transmission. The people that contracted HIV in the original pivotal study that led to the approval of TDF-FTC or Truvada were people that had drug exposures less than 4 tablets per week. And it was really based upon that understanding that the Ipergay and the Prevenir studies were designed and showed very comparable reduction in risk as well. So this just looks at, again, the time to protection with daily dosing of FTC, TDF, or PrEP. And now WHO recommends additional HIV prevention measures to be used within the first 7 days. And we generally have this rule of thumb that it takes about 7 days for target levels to be achieved steady state for rectal tissue penetration, and a little bit longer for female genital tract. We see that at least for, if you look at daily doses, it takes a while for maximal protection. In the female genital tract, it takes a little bit longer than in the male genital tract, rectal tissue. These certainly apply to both men and women. What we don't know is more current data with TAF, and there are some, certainly the concentrations in PBMCs are achieved much more rapidly and much more quickly. And again, is that the same thing as protective effect in tissue? Remains to be seen, but certainly TAF PBMC levels are achieved at much higher level, much quicker rates than TDF PBMC levels.